Welcome to this meeting of the Healthcare and Wellbeing Scrutiny Committee being held today, Monday the 29th of July 2024. My name is Councillor Pauline Crockett. I am the Chair for this Scrutiny Committee, and I again would like to welcome everybody and thank everyone for their attendance. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is also making a recording. For participants in the room, please use the microphones to speak, pressing the button on the right-hand side. Speak directly towards the microphone, otherwise your contribution may not be picked up on the live stream. Please ensure that mobile phones, laptops and other devices are turned to silent. Others are permitted to film, photograph and record public meetings, providing that it does not disrupt the business of the meeting. There are no members of the public at this meeting, so I won't dwindle on that. Only committee members present in the meeting room may vote. We have a number of people in attendance as virtual participants. Can I ask that they use the raise hand function within the system if they wish to contribute and introduce themselves when they are called upon. Okay, so item 1 on the agenda is for apologies for absence, and apologies for absence have been received from Councillor Mark Dykes and from Christine Price of Health Watch Herefordshire. Item 2 is named substitute, and we are welcoming Councillor Louis Stark at present in the name substitute for Councillor Mark Dykes, and thank you for attending, Councillor Stark. Item 3 is declarations of interest. Do any members wish to declare any interest on any agenda item? No heads there. Item 4 is the minutes. The minutes documented of the meeting held on the 25th of March 2024 are included in the agenda pages 11 to 17. No matters of accuracy have been notified to the monitoring officer, so are you all content that I sign the minutes as an accurate record? Thank you. Item 5 on the agenda is questions from members of the public. A question has been received from a member of the public, Mr. Phil Smart, and a response has been published in the supplement page 3, supplement 1. The questioner has the opportunity to submit a written supplementary question or to join the meeting to ask their supplementary question. Can I ask the clerk to confirm if a supplementary question is to be asked?
Yes, thank you indeed. Yes, Mr. Smart has submitted a supplementary question, which I'll just share on the screen for everybody in just a moment. There we go. So the question is, it's clear that there is a desperate need for a separate housing and homelessness scrutiny committee, given the recent ruling from the local government and social care ombudsman, where a family was awarded £13,580 in compensation for being placed in unsuitable accommodation. Will the committee recommend to council that it create such a committee?
Many thanks, Mr. Smart, for your supplementary question. The committee discussed your suggestion at a briefing earlier today, and we recognise the importance of providing a high standard of accommodation for people in Herefordshire, in particular those who are homeless as well as those for other vulnerable groups. We believe that this committee is well placed to scrutinise the council's work in this area, so we will not make a recommendation to council for a scrutiny committee dedicated to housing and homelessness. We welcome any further suggestion you might have for topics for this committee to look into. Thank you. Item 6 on the agenda is questions from members of the council, and we have not received any members' questions. So, moving on to item 7. This is the meaty part of the meeting, So I'd like to welcome Jane Ives and Lucy Flanagan and John Barnes. I was just trying to think, John to the meeting this afternoon. So the purpose is to have a look at the Care Quality Commission's background and findings of the inspection at Wye Valley Trust, which took part last December. And again, I thank you for your attendance. So I believe there are some slides to be displayed. So I've talked to the committee members, and if there's something really burning, we'll ask you to answer it at that slide point. But if not, is that okay if we just carry on and you just carry on, and then we go through it that way? Okay, so over to you, Jane. Oh, sorry. I forgot to say, Councillor Andrews wanted to just comment on
say something. I think I'm probably the only member of this committee who's actually worked in an accident and emergency department, both in this country and abroad. And I read this report. All I can say is I have the deepest sympathy for the clearly hard-pressed staff of the department. And I know that the department itself is too small for the demands placed upon it, and I would just like to say that I express my sympathy to all the staff concerned in what I think is an extremely unpleasant report.
Thank you. I've got the slides. Okay, if you go to the next slide, please. Thank you, that's lovely. So I'm just going to give a bit of an overview to start with, then I'll pass to my colleagues to go through some of the detail. But really welcome the opportunity to share what we've done since that report. And Polly, I agree with you. It is a very pressured environment to work in, and of course that's part of a national context where we've seen, since COVID, we've seen, a significant increase in emergency demand, and we've seen, poor performance right across the NHS in terms of our previous A&E standards that we were able to achieve. So the cause of the difficulties really are around a very congested emergency department. So too many people there. And the reasons for that are threefold in effect. One is that increase in demand, particularly demand for those people who are more unwell and require admission. Discharge delay increase, which has blocked the rest of the hospital. Now, this was in December when I think we were probably at our worst in terms of discharge delays. I mean, they are about half now what they were, and we'll talk through some of that improvement that's taken place. And then the third reason for the ED congestion is that we took a very deliberate decision that we would prioritise offloading ambulances, because for all of emergency care, those who are waiting at home for an ambulance and they can't get an ambulance to attend are those that are the most vulnerable. So we prioritised offloading ambulances at ED so that we could release the ambulances to go and get the next set of patients from home or from the road or wherever they were. But of course that again increased the level of congestion in the ED. So those are the broad drivers of this, and we'll go through more of the detail, but just in overview. I want to leave with a bit of a positive before moving over. So our most recent data, which I got this morning, we are in the top quartile of performance nationally on time to treatment. So from when you arrive at ED, how long does it take you to get your treatment? And we are in the top quarter nationally in that. We're in the top half in 4-hour performance. Now that still isn't great. If you think where we were, if we go back to 2010, we were regularly achieving 95% of people managed within 4 hours. I mean, that is now around about 68%, but we're in the top half of the country even with that performance. And then the other piece of information which I think is reassuring is we monitor our mortality statistics, which generally is driven by emergency admissions. Generally, if you're coming in for an elective procedure, your outcome isn't to die. And for the first time, our mortality indices have dropped below 100, so they're now below the national average. And that's testament to all of the hard work that our staff do right across the organisation, but not least in ED itself. However, we remain a very congested department. We're a very congested hospital. We have around 30 boarding patients most Mondays. So today we came in and there are 30 patients boarding on the wards. That means that there are 30 patients in beds where there isn't a bed space. So it's the 5th patient in a 4-bedded bay, those sorts of things. So there's a broad range of actions and things that we're looking at, both ourselves and with partners, around what can we do. But again, I'll go back to this is part of a national, we're not alone in this, but we're only responsible for delivering the things that we can do. So this is the thing that's absolutely top of our agenda, making sure that we are making improvements in emergency care. So I just want to sort of give you a little bit of overview to start with, but then I'll pass on to colleagues to talk about a bit more detail about those, and particularly around the CQC finding and what we've done about those.
Thank you. Next slide, please. I'll try and talk to this freehand rather than follow the script. We put a bit of narrative in so people just reading it would understand something, but I'll talk it through as I understand it. So top left is performance, so that's number of patients treated and discharged within 4 hours, and you can see the uplift, which was March of this year, where we had a bit of additional money from the centre, from NHSE, to do a test of change, which we did, and much of that test of change continues now. You can see performance took quite a nice little uplift actually, and we did quite well compared to other trusts as one of the most improved in the country. Can't remember the actual stat, but we did really quite well. As Jane says, though, it's still way below where we'd want it to be. Top right, you've got attendances, type 1, which is attendances to an accident emergency department, or emergency department nowadays. You can see they're just a gradual growth. It is a false origin there, so you started at 4,000, so it's a bit exaggerated on that chart, but there's a general growth. It's certainly busier than it was pre-COVID. So we used to talk about 180-ish, as COVID struck, it's now 200-ish. So we have seen but some of that was just background growth, and some of that is people seeking out healthcare. Conveyances actually went down from pre-COVID slightly, so they're just under 60 now. They were 63 as COVID struck. So, and some of that, there's lots of different narratives. Some people worry about the response time from ambulance now, so some people make their own way to us where they wouldn't have done previously.
John, could you just explain what conveyances are, and also a bit more on the type 1 only?
Right, okay, I can do, yes. So conveyances is the word that we use in the health service to ambulances go out to a person and they convey them to hospital. So they convey about 60%, I think, of people to hospital. 40 they'll see and treat on the scene, so they'll patch them up or say you're okay, I'll just pick them back in the chair or whatever. So conveyance is lifting the person up from the place of injury or ill health and taking them to hospital.
Are you saying 60% come by ambulance and 40% come by other means?
No, so of those calls that the ambulances send the vehicle to, they convey 60% of those people they go and see, and they leave 40% where they are. And type 1, wasn't it? So roughly 3 types of emergency attendance to count, how they count it nationally. Type 1 is a consultant-led accident emergency department with all the things you'd expect. So an A&E, a casualty, an emergency department. Type 2, I think, is a walk-in centre type activity, and type 3 is a specialty A&E, like an eye casualty or dental, emergency dental practice. So that much more specialty based department. So most of our activity is type 1, so most of our activity comes from the hospital itself. Conveyances, I think I've talked about, and then admissions. Again, false origin on the graph, so it's slightly exaggerated, but you can see a growth in admissions. Some of that is around same-day emergency care. So same-day emergency SDEC, you can see the abbreviation. Oh, sorry, I forgot to put the long hand of the SDEC in. Same-day emergency care is admitted and discharged on the same day. So you have more than an accident emergency, so you'll go into a ward, in our case, an SDEC or an AMU, and if you discharge on the same day, that's a 0-day length of stay. But we still count you as admission. But for our purposes, we often like to exclude those same-day ones because they don't consume beds in the same way as inpatients stop overnight do. So we'll usually clarify which one we're talking about. So some of that will be growth in same-day care because we do a lot of that now. We've got a frailty same-day emergency care unit, we've got a medical same-day emergency care unit, and we've got a surgical same-day emergency care units. So some of that growth may be that, but some of it absolutely is inpatients. And we think it's about 5 a day, I think, Jane, we've got 2 now. So 5 extra patients being admitted a day, stopping around about 7 days, I think, which consumes 35 beds, which is 1.5 wards, which is the real driver of the pressure here. Next slide, please. So care groups, I don't think this tells us an awful lot. You can see, let's see better on the screen. You can see top left there, you've got resuscitation unit, which is where we treat the sickest patients that need immediate care, whether they be a heart attack or a trauma or something else. That's definitely, there is growth there. That's nearly a proper origin and real growth there. So we are seeing some sicker patients coming through our accident emergency department. Top right, there's definitely that's the growth really. Cause that's majors is you roughly have a number of departments within an emergency department, but minors is where you treat people with minor illness and minor injury. Majors is where you treat people that need a more of a response. They're sicker patients, and we're seeing growth within our majors department and our resource. So the sicker patients and the sickest patients are growing in terms of attendance, and that's where the growth's coming from. Minors is just some variability there, isn't there? Relatively low number. There's about a third of the volume of majors, and then paediatrics is pretty flat. There's not really no real growth in paediatric attendances. The variation is winter disease. Is that stuff that they get in the autumn and often through to the spring. So you get very busy in the winter and then calms down in the summer. So move on to the next slide, please.
John, could I just ask you a couple of things on that one?
Yes, of course.
For instance, resus, you've got the blue and then the black. Is there any reason for that?
The blue is within normal variation, I think, and normally it was the orange was special cause, wasn't it? Where something had gone on.
And then majors, you've got the colours exactly the same, and then minors, you've got the three different colours, and
I
also
think
with
because
peds.
I think the orange for majors because they're all out of range. If you look at that as a standard control chart, so see that little dotted line, just under 3,500. That's the upper control range. So it means every single data point there is outside of range. They're not where they're supposed to be. That the original when that upper control ranges was calculated, that the black line would have been the average, and the variation should have stayed within those dotted lines. Where the growth is so much so that actually we need to rebase that, don't we? Because they're all outside that range. Yeah. So that's what the orange is showing, sort of outside of range. I don't know why the black's there. Blue's within tolerance, either reducing or within the range.
Because that theory doesn't really equate to the minors graph, does it? You've got black at the end that are below the solid line, never mind the staggered line. But you're saying that the interrupted line is where you would expect it to be.
When the calculation was first done, so it's calculated by a formula rather than by a person. That you put in a data series and it calculates what your average should be and what your ranges should be. It looks like it needs rebasing.
We love computers, don't we?
Yes. Yeah.
Councillor Bartlett.
Thanks. I'm intrigued. I mean, this is an odd question, I know. I'm intrigued by this slide altogether because obviously we were supposed to have been doing this back just before somebody decided we'd have a general election instead of getting on with our lives. And it's completely different to the slide that you were going to present then. I just wondered.
Well, it's been updated.
It's been updated.
We've got another 3 or 4 months.
Yeah, that's all.
Okay, so right, okay, it's just a completely different. I just wondered why it was different. Thank you.
Okay, shall I carry on? Yeah, next. Oh no, this is minors, isn't it? So really, I think we've got PCNs here. So the top graph shows all of them.
Sorry, John.
Yep.
Sorry, it's me again. Because not everybody has a medical or clinical background, could you just explain? I know PCN, we all understand it's primary care network, but for the people who are watching this online and also some of us, could you just explain any acronym or abbreviation?
Yeah, okay, so the top graph shows the number of patients attending emergency department with a minor injury or illness. So people that we would treat in the minors unit I talked about previously, which is about a quarter of the entire activity within the department. So what that shows over time, you can see that goes back to August 19, right through until June of this year. and we split it by PCNs, primary care networks, the 5 PCNs within Herefordshire, and you can see really all we've got there is variation. There's no growth, and there's also no growth following the closure of the MIUs pre-COVID. I think it was October 19, so which we tracked carefully at the time and since. So it doesn't tell us an awful lot other than the fact there's not a lot going on in minors. It's mostly going on in majors and in resources, as I spoke about earlier.
Just pause there for a second. Councillor Stark.
Do you believe there's a correlation between the number of patients with minor ailments attending Hereford and the 40% of patients that are not conveyed by ambulance to Hereford? Is the ambulance service taking up some of this slack? That's what I'm getting at, with people not able to travel to Hereford. For example, Ross, the bus service is terrible and a taxi is about £50. So is it possible that rather than you seeing them yourselves, that it's actually putting more pressure on the ambulance service?
I think that's unlikely. It would be unlikely for the ambulance service to task a crew to go to somebody with a minor injury or illness as described on the phone. They would do something they call hear and treat. So they talk to them on the phone and they would triage them and direct them to self-care, pharmacy or whatever else. So they wouldn't spend their time for sort of category 3 or category 4 ambulance to that sort of volume, which is probably what, 50 patients for them it's probably, so I think conveyance is about 50 for them, so it's about 12 patients a day.
So the 40% of patients who are not conveyed to accident emergency but treated at home, what sort of ailments have they got then, and why are there so many being treated in that way?
It could be people with infections that don't need hospital treatment can be sourced. So the ambulance will sometimes contact general practice. They'll contact our own 2-hour urgent care response, which we run alongside general practice. So they might deploy a different health resource there to go and treat them. They might advise treatment themselves. So it might be somebody who thinks they're having a heart attack and they've got indigestion, or they've got, I can't imagine what it would be, but they don't convey them, and that's pretty standard across the country. That's not unusual. That's pretty much that. It has improved improved by our perspective is they bring less people to us. So it's reduced, the number of conveyances has reduced proportionally and numerically since COVID. But that seemed to be a good thing.
I don't understand what's a minor ailment and what isn't a minor ailment now. That's what I'm getting at, but I'll leave it at that for the time being.
I could probably try and have a... Sorry?
So if I take, for example, my next door neighbour who's now deceased, she would have a fall.
Yep.
The carers were not allowed to pick her up. She wasn't actually injured, so they would have to call a paramedic, and a paramedic, they would go out and they would pick her up, check she was okay, put her back in her chair, and then go.
Yeah, some of that. We've also got a falls response service that do some of that, but yes, ambulance certainly would be tasked to some of those jobs. I mean, minor injuries and minor illness, and minor injuries, twisted ankles, broken wrists, things like that, things that don't need a resource and a surgeon to fix, really. So just small injuries, but things that need treating, things that might need a tetanus or that sort of stuff, or cuts and sprains, might need a few stitches. So minor stuff you can manage in a normal room with normal kit. You don't need any sort of a big response, if you like. Minor illness would be, I don't know, would be perhaps a mild chest infection, feeling of dizziness, headaches, those sorts of things. Things that.
So all these patients with minor injuries have made their own way to Hereford.
Pretty much, they'd be.
I don't understand that either. I mean, why there's no intervention somewhere along the way to direct them, as you said, to the GP surgeries or somewhere else? The
main message for me would be that minor injuries, minor illnesses are relatively easy to deal with with an emergency department. They aren't driving our problem. The people that are driving our problem are those with complex needs, whether they need immediate resuscitation in our resource department, have you seen significant growth, or whether or not they're in our majors department and need a lot of intervention from a number of teams and may then require a hospital stay. That pressure on our inpatient bed stock, which has grown quite a bit over the last few years, but not enough to keep pace with that 5-a-day growth, that 35 extra demand, which is more than one ward. There's 1.5 wards of extra capacity we don't have, and we're having to find solutions to. So yes, the minors is you would like to provide the quickest response and the easiest response and a nice time response for all the people, because there's still a problem for them. It's not a major problem. We don't describe it as major, we call it minor, but it's not what drives an emergency department's pressure.
Yeah, just in terms of that minor injury as well, it's just, I mean, often this is the sort of thing that you need an X-ray. So you need to X-ray the hand or the foot to see whether it's a sprain or is it a fracture. So it would still require some other resource often, but it's a whole range. But the majority would be minor injury.
Do you think it affected the CQC's assessment of you though, in terms of performance? The minors.
I think I may not be exactly right, because I think our minors' performance is around 90-odd%, might even better than 90%. So if you come into our minors, 90% of you will be treated and discharged within 4 hours. So once again, I think underlines that point around it's majors that drives the problem.
Councillor Andrews.
Yes, this is all very interesting, but what we're dealing with here is the CQC report, who made an awful lot of criticism, some of which I think are justified, but still. But what we would like to know is how you are proposing to respond to them. I mean, one thing that I noticed particularly, and this I take it as a long-term problem, is the fact that your IT systems apparently don't speak to each other.
Can I suggest we get to that on the presentation, because it
Yes,
so this is
but-
just trying to explain
Yes,
the
but
context.
so
we'll-
there's
we will
quite a
move
lot,
on to
quite a
the
lot
report.
here that I think we'd like to know just how you're going to respond to them, whether they're justified or not. And some of them I don't think were justified.
I'll try to not abbreviate things, but get through these slides quickly so we can get to that stuff. Okay, so this one here, I don't think tells us an awful lot, but it just tells a little bit of something. So you've got QC1 on the top left, to very urgent, to standard, and low on the bottom. As you can see, the low acuity is not changing, that's your minor stuff. There's a bit of growth in the standard stuff, and I think from very urgent to urgent, I think they're just swapping over each other there. I think the quantum of the two isn't really changing that much. I think there's a bit of background growth. So I think really it's those standards, that majors patients again, I think that are driving the problem. So if we go to the next slide. So this is performance. Top left is handover within 30 minutes. You can see that was at 80%. We were doing quite well through COVID and beyond, but then we have struggled a little bit more. It's down to 70%. I say that benchmarks quite well with other providers within the Midlands. Not as good as we'd like. We think it's really important to achieve as high as we can with this. We really do want people getting ambulances quickly when they're at home, particularly around that Cat 2 performance, which is the urgent but not immediate category. Ambulance handovers within 60 minutes. I think this means ambulance handover over 60 minutes, so my apologies, it's mislabelled. But you can see there it's spike back in, I can't read that from here. Last December, which is when the CQC visited actually. So we've kept it reasonably sort of below 10%, 8%. I think it's back down to something like that sort of level, isn't it now? So we're back down to about 8%. Patients spending more than 12 hours in ED. This is another. This I think informs that congested ED story, which is really the story of the CQC for what they found. It's what they talked about. So this is lots of people sitting in ED for a long, long time and not much space for our teams to work in. And then I think the biggest story, patients with the decision to admit at 8 a.m. So you can see going back to pre-COVID and through the first parts of COVID, up until January 22, we were keeping 5 or 6 patients in the department each morning. They were okay. They'd probably come in overnight, waiting for a review in the morning, and then we'd get them to a ward or home. That's gone up to 20 to 25 most of the time now since then. And unusually, we haven't been able to move this figure at all since the winter. We're still exactly where we are today, exactly where we've been since December last year. We've hardly had any respite at all from that sort of volume of patients, and that's with us taking multiple mitigating actions to make space for people. we just run out of space. So, next slide, please. Discharge delays. This doesn't represent the progress that we've made, and Hilary and I are waiting for a data dashboard to show us better around these things, because data historically has been very poor. It's council data and it's health data, and it's been difficult to get it together. We have got a dashboard created. We're just waiting for that to be finished, and we're going to share this stuff properly. Roughly, though, through winter, we were carrying 60 odd patients that didn't need to be in hospital. They were either in our community hospitals or in the county hospital. They were about 60%, well, probably, no, 90% was Herefordshire and Powys, so our local population. 10% was from elsewhere, typically Shropshire and Worcester, occasionally Gloucester, but mostly Shropshire and Worcester. And of that 90%, the split is 60-40 in terms of Herefordshire and Powys. So of that 90%, 6% of that 90% is Herefordshire patients and 40% is Powys patients. That Powys proportion is much, much higher than their market share. About 14%, I think, of the market share is from our Welsh neighbours, but they've got 40% of our delay. They do have a significant medically fit for discharge problem in Wales, particularly around social care capability and capacity. We are working with them closely. Both my Herefordshire colleagues, Hilary and her colleagues, have worked hard with us, with Powys Council and Powys Teaching Health Board to try and improve this, and we just met with them earlier on today, actually, to try and tackle that. Not that Herefordshire didn't have its own challenges, it did last winter, but I'm pleased to report that Herefordshire problem has reduced significantly. The work that Hilary's team has done, particularly around the domiciliary care market, has really eased the pressure. So we're now, I think this morning was a bit higher, it was 41, but we've been down in the 20s where we used to be in the 60s. And that's mostly Herefordshire's contribution in terms of reducing the pressure. So there's been great work. We've now got an agreement in place which supports joint working between health and council, and we've done a lot of joint work in terms of reducing medical fit for discharge delays, and we'll continue to do so. We have high hopes about managing this jointly going forward and making further success. So I don't think these graphs do it justice, the joint work. The graphs to come will hopefully show. We think the delay now for a pathway 1, so a support at home discharge, 6 months ago it was 4.5 days to wait for that, which is a long time. Most people manage 1 to 2. We think we're managing 1 to 2 at the moment. Can't prove it without doing an audit. So the dashboard will show us every week what our performance is, and that's much better for patients, and obviously much better for the hospital. Okay, next slide, please. Acute bed occupancy. I keep starting the same story the same way. So it's quite a short data sample. You can show last summer, if you like, that green spell. So that we'd got more beds than patients for some of the time. That sort of changed around about October, and nearly, except for probably New Year's Eve and Christmas Day, there's 2 green spikes. We've had more patients than beds. And the graph below that just shows, again, the same story. That's the number of escalation beds we've used. So that count doesn't include the patients stuck in ED. So that's the amount of people we've housed outside of normal substantive beds. The 20 odd in ED, you have to add to that. So it's often, so that just tells a congestion story. And then the next slide is Lucy's. I'm finished for a little bit. That's okay.
Thank you. So I'm going to talk about the CQC inspection itself, but we thought it was important just to set the context for sort of that pressure that the emergency department and the hospital were experiencing, particularly in December, which is when the CQC inspected. So the CQC inspection regime, they use both unannounced and announced inspections. So the inspection that we had in December was unannounced, which means you get half an hour's notice. So the CQC came to site at 8 o'clock on December the 5th in the evening, 8 p.m. in the evening, having phoned us at 7:30 to say that the inspection team would be on site. And they stayed throughout the whole of the 6th, and they left site about 5 o'clock on the 7th of December. So the inspection that they undertook was what's called a core service inspection, which meant they looked at our emergency department only, and it was a focused inspection. And what that means is that the CQC look at all of the domains that are within their framework. So the 5 domains within the CQC framework are how caring and compassionate is care delivered, how responsive is the service, how safe is the service, how effective is it, and then how well led the service is. Now, the reason they undertook a focused core service inspection is because within their remit, they can then adjust your ratings according to what they found. Next slide, please. So,
Before you go on, just sheer interest, what sort of background do the inspectors actually have? Because we understand that social services can't get anybody who knows anything about adult social care. Do any of these people have any actual background in emergency care, for example?
So in relation to this inspection, so the team that visited on the evening, the first evening, involved our CQC relationship manager, who happens to be a nurse by background, a surgical nurse by background, so not an emergency department nurse. And then they brought a management inspector who may not necessarily have worked within a hospital setting previously. On the full day, the next day, the full day, they bring specialist advisors. So they weren't able to deploy an emergency department consultant specialist advisor, but one was available for them to consult with in relation to the inspection. And then the team on the inspection day was made up of a mental health advisor, there was the nurse that we'd already had, a management inspector, and one other clinician, a pharmacist by background. So a mixture of advisors, but that's because they come in to look at their specialist areas. And then on the final day of the inspection, we had our relationship manager, who's a nurse by background, and one of their management inspectors. And actually in this instance, one of the CQC's regional directors shadowed the inspection, but that was because they had not seen an inspection before, so they shadowed it. Are you happy for me to move on?
Yes, do.
Okay.
I just feel that there seems to be a certain lack of appropriate expertise, if I may phrase it that way.
So during the inspection, there were a number of things that the CQC felt required urgent attention. And part of that was our emergency department provides 24-hour care to paediatric children and young people accessing our services. And we have paediatric nurses supporting the department. And in addition, we have general nurses who have paediatric competencies, specialist training in terms of safeguarding for children and young people. And the CQC were a little bit concerned that some individuals' training was out of date. So their statutory and mandatory training, which you're required to renew on an annual basis, some of that hadn't been renewed in a timely way. So there were some concerns. And I will talk in a moment about how we address these things. Our department were delivering, so there were concerns around our triage process, and what our department had been aiming to deliver was what we would class as gold standard, best class triage. What happens when you've got a congested, busy emergency department is actually the ability to deliver that gold standard triage is more or less impossible. And I think the team had been trying to continue to do that. And what the CQC saw is actually you need to triage all of your patients very quickly in order to determine the level of risk that each patient presents with.
Lucy, can I just say that's a really interesting comment. Sadly, I had to go to A&E not long ago, and the receptionist triaged me and said, you need to go to minor injury unit. So I went round there, really grateful to that because the waiting room was heaving. So I went round there, seen by a nurse, had an x-ray, yes, I'd broken my leg, so they then put in my follow-up. But what I'm trying to get at now is why was it left to that receptionist to say, you need to go to minor injuries unit? I told her I'd hurt my leg, finding it difficult to put any weight on it. it was the right decision, but, you know, for a receptionist to tell me, you know, what I needed, I thought was a bit above her position.
So I'll explain what we do now, but I'll also explain some context to that. So we have a nurse navigator at reception now who navigates all patients presenting at reception in terms of whether they could go to same-day emergency care, minor injuries, or straight into resus, for example. So the nurse navigator is now present, and that's been since March, since the test of change that Jane and John alluded to. At the time the CQC visited, we did have some very clear guidance for the receptionists around below the knee injuries, cuts that weren't oozing with blood, that they could navigate to minor injuries, but it was against some very, very specific guidance. The issue here was, in a congested department, we were trying to get doctors to see patients immediately at the point that we triage in order to get treatment and tests underway straight away, which is really difficult in a congested ED. And what the CQC wanted us to do was to go back to nurse-led triage, because that then means everybody's triaged within 15 minutes, is risk assessed as actually you're perhaps lower risk and can sit back out in the waiting room versus somebody who absolutely needs to come through to commence their treatment pathway. So the CQC was just saying actually you need to go back to nurse-led triage given the congestion in the department. There were some concerns over the frequency of undertaking observations for patients. So by observations, I mean taking your blood pressure, your pulse, your temperature, so some basic baseline observations. We had a standard operating procedure that said everybody in the department needs them doing as a minimum every hour. Well, actually, some people don't need them every hour. Some people might not need them at all. If you've cut your finger, you won't need your observations doing more than once. So there was some queries around us not following our own standard operating procedure, but actually in retrospect our standard operating procedure set us up to fail, if that makes sense. There were concerns over the management of sepsis, particularly in the context of delivery of antibiotics within the time period described in best practice for sepsis, and again was a symptom of just how busy and congested the department was. They were concerned because of the congestion. We had patients in fit to sit in the corridor and a very busy, as Councillor Crockett alluded to, waiting room with lots and lots of patients in there. And they were worried about our oversight in terms of clinical oversight of those areas. We did have healthcare support workers to oversee those areas, but the CQC felt that that wasn't enough. They were concerned, somebody alluded earlier to the two information systems that we've got. So within our emergency department, we use something called Symphony, which is designed to manage those patients coming through the emergency department up until the point a decision to admit them is made. Once a decision to admit them is made, then those patients are, if you like, transferred onto our inpatient computer system. Now, ordinarily, if you weren't congested, the patients where a decision to admit has been made would be moved out of the department into a timely way, so those two systems and the interface between them wouldn't necessarily be an issue. But because those patients, as John alluded to in his presentation, we might see 20, 30 patients in a morning waiting within the emergency department for a bed, meant that the nurses and doctors were having to navigate between two systems. And whilst the nurses and doctors were trained in the two systems, the CQC felt that there was the potential for us to either miss medication doses if you weren't looking on the right system, or the potential to make a mistake because you were having to look at two systems to manage that case mix of patients.
Are you proposing to amalgamate these systems? I see it was 2025 is the figure, the year given. Surely, can you not manage it?
So I'll come on to that in a moment, if that's okay. And then there were some minor environmental matters that we needed to deal with. Next slide, please. Perfect. So given the CQC's concerns and matters that they discussed with us during the inspection, We held a safety summit on Friday the 8th of December, and the safety summit was attended by all of our executive management team, the team that lead the division that the emergency department sits in, so the senior nurse, the senior doctor and manager, and then members of the emergency department in terms of doctors, nurses and the wider multidisciplinary clinical team. We held a summit on the Friday afternoon, and these are some of the things that we agreed through that summit. So we put in additional staffing arrangements to support the healthcare assistants that were looking after patients in the corridor, in the waiting room. We put in registered nursing workforce to support that. We provided additional support from the paediatric ward in terms of more paediatric nurses to support the department if the department weren't able to staff it with people with the appropriate competencies and level of training. We agreed to revise some of our standard operating procedures. So you probably heard me say, we developed an observation SOP that said we'll do everybody's observations at least every hour. We were sort of setting ourselves up to fail, so we've revised that to be much more responsive to a patient's individual needs. We revised our triage standard operating procedure and process to make sure that we had nurse-led triage early on in the pathway. We revised our sepsis management standard operating procedure as well. And in addition, we agreed to do a number of baseline audits so we could understand where we were starting from in terms of documentation, observations, the medications issue, so the issue between the two systems. We agreed to audit that to assure ourselves that patients were receiving timely medication and that there wasn't the potential for error. And we enhanced the quality of sort of checking that those patients who would not normally be in the emergency department, who were waiting for a bed, those 30 patients in the department waiting for a bed, just to make sure that we had care planning for those individuals and nurses checking on those care plans, because actually emergency departments care plan in a very different way to ward-based nurses. So we agreed to do some additional care planning and provision for those individuals. We resolved the environmental and estate matters, and we were able to, between the inspection that took place in early December and before the CQC revisited on the 20th, we launched our emergency department dashboard. Now, that wasn't in response to the CQC, it was something that had been in development for 12 months, but it was ready to launch, and we launched it the following week. Next slide, please. I don't plan to go through the dashboard. It is here pure. This is a screenshot of the live dashboard. What this really helps with is what I would call situational awareness. So what this enables at a glance at the screen, and it is projected onto a large screen within the emergency department, is it's got some performance information in there, so it'll let you know how many patients are in the department, what the time to triage is, how long they've been waiting, but it also highlights who's your sickest patients and when are their next set of observations due. So going back to that observation policy, some patients need their observations doing every 15 minutes, for example. What this dashboard does is just increase the situational awareness, both for the nurse in charge, the doctor in charge, and we have got what we call progress chasers in the department, who are individuals who will chase blood tests, blood results, beds, etc. So it just enables better situational awareness, and we were able to show the dashboard live in progress when the CQC revisited on the 20th of December.
Lucy, could I just ask you something about this dashboard?
Of course you can.
So that is for the doctors and clinicians to see, yeah?
Yes.
So if somebody was needing regular observations, that would come up on here, and your nursing staff would then ask your care staff to go and do that, would they?
So the nurses have so
is this in the pit stop?
This gives you an overview of everywhere. So the pit stop, majors, resus, everywhere. Now, we'd expect the nurses who are caring, so if you're in majors, you'll have responsibility for 4 patients if you're a registered nurse. So we expect that you'll know that your 4 patients, how frequently they need their observations. What this helps is it would help the nurse in charge of the whole department have a helicopter view of where are my sickest patients. And actually what this would do is it would just flash if some of our sickest patients' observations were due or overdue, the dashboard would alert an individual to it, so that the nurse in charge could prompt the individual to say, you haven't forgotten your observations on that patient in that cubicle.
So in the pit stop, it's a bit different because there's 4 beds in there, isn't there? So that overall nurse in charge there, she would be looking after those 4, keeping an eye on when they needed observations, etc. And then also the ones out in the corridor that they couldn't accommodate, is that right?
So the nurses caring for the patients have oversight of their patients, what they need to do. The dashboard is there just to help everybody know who's where in the department and what their level of acuity is, if you like, and what's required. So it's just to help. I mean, we use the dashboard, for example, in our bed meetings, for example, because it will tell us how many patients who've got what we call a new score, which is a national early warning score, that says, actually, these are some of your sickest patients. Where are they? What's the plan? So it's designed really as an overview tool rather than how people manage and organise themselves to deliver the care to patients, if that makes sense.
Yeah, and I'm just trying to think, is there a simpler way? Especially, I keep on about the pit stop because that's where I've had a few visits with my mother. So basically, if she had the 3 things she needed really swiftly, such as observations, bloods, X-ray, she could have been in and out of there in maximum 4 hours, I would have said, but she was in there 10 hours. It took 2 hours to do obs, 3 more hours to do bloods. X-ray I kept chasing about. So, you know, I just wonder if the care workers who are in there working their socks off, you know, going from one to another, if they had a visual, I don't know whether it would be a number system in the bed space that the person's in, so that they knew 1 was observations, that hadn't been done, 2 was bloods, that needs to be done. I don't know. I'm trying to help get that flow working a bit better, and the time that you're having to stay in the department you don't need to be in could be simplified.
Yeah, I think where we are is that there's say, this is a tool for whoever's in charge of the department to understand if they've got risk. And it may well be that, as you say, the person who's looking after 4 people, actually they've had 3 more people come in, they're all much sicker, so they haven't got time to get to them as quickly, so actually the person in charge can work out where the workforce needs to be. So this is an oversight in managing the whole department and managing risk. As Lucy said, for the individuals who are looking after, you know, that group of patients, it's their responsibility to do that. But I guess the issue is in a very congested department where you've got lots of people waiting for lots of things and they're queuing up, and part of that queuing up is you haven't got a cubicle to see someone in because they're full of other patients who are there. Things can then start to take a very long time. This is around managing risk and managing safety, but also part of this is around how we resource ourselves in a different way, and also how we do the other wider things around either reducing demand or increasing flow through the hospital. Because actually, if we could discharge the patients from ED into the ward at the point they needed it, which is generally within 4 hours, they'll know that, then you're not congested and the staff can get to the next patient and it resolves the issues you're talking about. So this is a broader systemic approach to it. But in the meantime, we have to manage the risk on the day with all of the patients. So hopefully that
Yeah, absolutely. We all understand. I think, you know, we got that funnel effect. You've got everybody coming in and you've got this very narrow exit, and the middle bit is the bit where you have to allocate wherever they can go until that funnel opens up. But, you know, we are elected ward members, and I'm sure all of us have had people say they've been to A&E, they've had to wait hours, they didn't do, and then they've gone home. You know, it's trying to help Wye Valley get people through as quickly as they can, safely as they can.
Absolutely.
Thank you.
Can I, Chair, can I
Councillor
just
Barton.
follow on to that? So I'm just looking at this from a lay person's view, obviously. when your head nurse is looking at this and you're saying that, or head who's looking at the overview that day, can understand where somebody is waiting for, either around sepsis or something like that, which piece of this screen would alert them to the fact that somebody has waited longer for one of these, either a sepsis check or one of the checks that you've referred to in the sepsis triage clinical observations? Which part of that dashboard would they automatically go, bed XYZ in department ABC needs to be gone back to?
Yeah, so on the, you can see the blue 4 squares on the screen. So I talked earlier about the National Early Warning Score, which is those very sick patients that you need to keep an eye on.
That's where I thought it was, but it's just not very clear to a layman. So, how does that get updated in the system?
So I'd start by saying I can understand why it's not clear to a layman. It's not designed to be clear to a layman. It's designed for the doctor in charge, the nurse in charge and the progress chaser to use as a situational awareness tool. Sitting behind that is the Symphony system that we talked about, which is our emergency department's information system, which is where there's lots more details about the patient. And so the teams use that as well for the management of their patients, but this dashboard gets updated from Symphony.
And does it get updated automatically from Symphony?
Live. Yes, live.
So at least these two are talking to each other. So.
Yeah, so it's live, so it gets updated, refreshed every 5 minutes. So.
And then that's the blue boxes trigger the warning, and that's how that automated system is managing that free flow. Thank you.
So if there was a 1 in there, if somebody's observations had gone past their time, it would go red in there, and the nurse in charge would go and prompt the nurse that was looking after them to say, you haven't forgotten, have you? But that's how the system's used. Are we happy to move on? Next slide, please. So I put this in purely for context. So the full report, as I said, the inspection meant that the CQC inspectors, because it was a focused core service inspection, means that they can then change the ratings. And so this is just the emergency department's ratings going back to 2015, which is the top. So you can see in 2015, this is actually when Wye Valley Trust was in special measures across the board and working hard to get out of special measures. And then you can see the subsequent inspections in 2016, 2020. You can see the progress that the department made in terms of where they ranked according to the CQC on the framework. And I think I would just describe that as a period of stability, sort of pre-COVID period of stability. And then what we've seen is the bottom box is obviously the ratings as per the inspection that took place in December of last year, where clearly it requires improvement across the board, with the exception of safety that was deemed inadequate for all of the reasons I've already explained, and thankfully good for caring.
Councillor Stark wanted to ask a question, I think.
I know it's a public meeting and you may not want to answer this, but do you internally assess the quality of the CQC inspection yourselves? Because some of that variability could just be an availability of the way the inspection was conducted and who conducted it and everything else. This is a concern I've got, because when I read the inspection as a former analyst myself, not a medical analyst, I felt there was a lot of randomness in it. I was worried about the lack of a systematic approach. I'm not saying the findings don't stack up, and it's a leading question to you, because I know you could give me this sort of answer that would say, yeah, or just ignore the CQC report. It's not what the paper is written on. And we have got the Secretary of State's observation we made. But one of the concerns I've got is trying to get assurance that this report adds value to what the patient's experience will be, to the safety of the patient and to the outcome for the patient. And that's what concerns me. Would you say that the quality of all these reports have been roughly the same? And does it provide a good guide to what you think your performance is in terms of emergency department for the people of Herefordshire and
So
elsewhere.
Happy to question that. So certainly as part of the process, so we sent a draft report, we can comment on anything that's inaccurate in it, and sometimes they'll make changes on that basis. But broad, I mean, clearly we knew the department was in difficulty. We were working really hard, and as Lucy said, you know, we were already putting together the dashboard, sort of saying we need something, so we've got some overview because this is very congested and chaotic. And as John says, he went through, actually we'd come out of sort of that summer in a bit of a better place, but between October and December it had really deteriorated. Partly we'd had this quite big increase in terms of medically fit for discharge, congesting up the hospital further, and we'd had the increase in what's continued in terms of more major patients coming. So we knew we had a difficult, I mean, the day they came, I mean, the week they came happened to be extraordinarily difficult, but their findings were fair. And I think we would say, yeah, we think those findings were fair, and we, it's carried on doing what we're doing, which was, it was the top of the priority list to make sure we could do whatever we could to do two things. One, make the patients as safe as possible, but secondly, to really look after the staff, because it's very difficult to work in that sort of you know, very congested environment where you know what you want to do for your next patient, but you can't get to do it because the space isn't there available. So both of those things are equally important. But no, the findings were fair.
Councillor Andrews.
Oh, excuse me. Since you now mentioned staff, I'll bring it up. I mean, one of the comments all the way through, I think, is you're having difficulty, like every other hospital, I think, getting suitably qualified both paediatric consultants, suitable consultants, and suitably long experienced nursing staff. And we make a point here that many of the nursing staff are comparatively inexperienced, and the more experienced staff have got to supervise them as well as look after the patients. Quite what you do about that, I don't know, because nursing staff are in extremely short supply. I'm sorry, I've been retired too long now to come back, but I just don't know quite what you do about that. But that seems to be one of the major problems, that you can't get suitably qualified staff, and you're having to employ extremely expensive locums.
I can talk to the nursing probably more than the medical staff here, but in terms of nursing staff, actually we have a fairly good recruitment in terms of our emergency departments. Our overall nurse vacancy factor at Wye Valley is down to, we're into single figures in terms of how many nurse vacancies we've got. And if we think, when I joined the organisation some years ago, our nurse vacancy factor was 140 whole-time equivalents. So yes, I'm not saying it's easy, but we are able to recruit. We do have a handful of vacancies for nurses within the emergency department, but you're absolutely right, the skill mix is more junior than it used to be. Yeah. So there is the requirement to supervise and support them as individuals. But we've done really well in that respect. Did you want to come in on nurses?
Yeah, I'll just come on the doctor's side. So we, I think when I first came to Trust, we had 1.5 whole-time equivalent A&E consultants. We are up to 5 now, but we're just going through a business case at the moment, which we'll complete in the next few weeks, that will see us go up to 10 consultants. So we'll reduce some of the more, again, junior doctors and put in more senior doctors. But you can't go from 2 to 10 in one leap. So we've got to our current budget. And the next step is to increase that further. So again, that will add further experience and oversight to it. But that's the next step.
I suppose another step would be to encourage people who are not either accident, not to block up the department, because so many people seem to come there for the simple reason they can't get a GP appointment.
Maybe we can come back to that at the end. We probably need to finish the CQC, and then I'm very happy to talk to those.
Could we have the next slide, please? Thank you. So, really good news that CQC found some really positive things, which is always good to hear, and was reassuring and nice for the staff. So good infection prevention practices within the department. Certainly a sense that, you know, that staff worked well together, and when the CQC inspectors were on site, they talked to the ambulance service, who liked coming to Hereford Emergency Department because of our strategy to offload ambulances to release them back into the community. So great teamwork, as I say, within the department, across the hospital, and with our West Midlands and Welsh Ambulance Service. Patients were treated with compassion and kindness, which is really, really important. They recognised that leadership was visible at all levels, so from the matron and the senior nurses in the department, but also from the sort of management team, executive team, that the staff working in the department under pressure felt valued, respected and supported by one another and the wider organisation, and that there was a genuine commitment when the inspectors were talking to staff around wanting to improve our services and make improvements.
How did the staff feel though when they read this report? You know, after all their hard work, to seem to be whatever they did was not good enough.
Certainly, a number of staff felt very disheartened and
I'm
quite
not surprised.
low when they read the report.
Yes, it does seem to depreciate all the efforts that have been made in very difficult conditions.
Absolutely. So if we could just move to the next slide. So for those individuals, I don't intend to read this slide out at all, but this is when the report's published, with all CQC reports, they make regulatory recommendations, some of which hospitals and service providers must do, and then they make recommendations around things that you might want to consider doing. Now, what's notable from the inspection report, given we were deemed inadequate for safety and had 3 domains that required improvement, was actually they only issued 4 must-do actions in the context of their final publication. And their feedback to us was, because we took them so seriously at the time they inspected, and then the improvements that they saw when they revisited on the 20th of December, I think is the reason we only got sort of the 4 must-do actions in the context of the whole report. So I don't tend to go through them, but essentially the top one relates to the triage, the observations, our standard operating procedures that we revised. The second action relates to making sure that those nurses that were caring for children's safeguarding training and paediatric competencies were up to date. The third relates to those patients that were waiting in the department for a bed. So how did we make sure they were receiving the appropriate care whilst waiting for a bed, that they received their medications? And the third bullet point absolutely relates to our wider strategy, which John's going to talk to in a moment. And then the fourth bullet point related to governance processes, and some of the things we put in place since the CQC inspected is a lead doctor leading on governance, a lead nurse leading on governance, and a robust audit programme. So that's essentially the 4 must-dos from the CQC report. Could just move to the next slide. I'm just going to cover where we are now. So Jane's already alluded to the fact that we're just about to bring sort of that second phase medical investment business case around medical staffing. We are bringing the business case to Trust Board for nurse staffing, but we're already staffing at that level. So we've not been waiting for the business case. We put those changes in immediately in December, and the business case is just to be submitted retrospectively. We have extended, so we have what we call Band 7 nurses, which are the equivalent of a ward sister, so senior nurses, highly skilled, and we extended their hours of cover following the CQC inspection, so they're now cover the department from 7 o'clock in the morning through to about 10:30 at night in terms of senior oversight. I've already alluded to the audit programme and the revised governance arrangements. We've talked about the live dashboard. This remains a significant priority for us even now today, sat here in July. So we do regular reviews of this, and our next deep dive of this is at our quality committee at the end of August. So that's to look at some of the audit outcomes to see where we were and how are we progressing against those changes that we've made. We're in the process of just revising what we call our escalation process. So we have an escalation process in relation to our beds in the hospital. So, you know, sometimes they might be okay. I can't remember the last time they were. And then at the highest level of escalation is when we're really struggling to come up with a plan for the next hour, the next or overnight. We need the same for the emergency department. We do have an escalation process, but it's written in several different places. So we want to bring it into one document. And the reason we want to do that is then we can be very clear around what our safety response, our quality response to that is as the department gets busier and busier. Those things are already in place. We just need to write it down. And we address the minor environmental and estates issues immediately following the inspection, but there was some more major work that actually requires parts of the department to decant in order for us to do some major improvement work in the department, and that's planned for August and September of this year. So
Don't ask.
don't ask.
It's very complex.
Very, very complex. But we've already done part of that. So we decanted, for example, the resuscitation area into our theatre recovery over a weekend not so long ago, and then for the following week. So we've already upgraded the resuscitation area, and that's now back in place. So we have to do it bit by bit, because we clearly can't close the department and move it somewhere else.
You haven't got a lot of space. No.
So that's where we are now. But as we've alluded to all along, actually, the way of fixing this, there's a much wider strategy. So I'm going to just pass you back to John briefly, just to talk about that wider strategy, if I may. Thank you.
Just before you do it, again, I'm going to go back to the... Sorry, I'm as bad as anyone else. Just before you do, and again, I'm going to go back to the CQC report, because obviously I'm just wondering what value it adds. Their findings are self-evident as far as I can see. Of course you want to have the right staff. Of course you want to have the right risk management system, etc., etc. What concerns me, and I know it's probably right across the care and the health service, do you think that service providers now rely on CQC inspections to do the sort of deep review that they maybe should be doing themselves regularly? And I just wonder whether all these actions that you've stipulated today, you couldn't have really done yourself without a CQC inspection. Just a thought.
But there's a whole philosophical debate, isn't there, around whether inspections improve quality or not, which probably is a longer debate for another time. This was absolutely an area of our focus, but did it provide an opportunity really just to stop and stand back from all of the redesign and all of the things people were trying to do that to make it better, which arguably had probably made things a little bit more complicated, and staff were maybe hadn't caught up with the latest operating procedure because actually they were changing so quickly. I think it added value, and it did give us an opportunity to almost just stand back and go, okay, let's just see what we've got, and are we focusing on all of the right things? And that doesn't mean that we would wait for the CQC to come before we would proactively do anything. I mean, an awful lot of what we do, an awful lot of what Luty does, and our quality committee do is focus and deep dive into different areas. But for me, I think this did add value. As I say, it was on a particularly bad week, but nevertheless, that was the week that those patients went through and had the experience that they had, and our staff had the experience that they had. So, but there's a wider debate around whether inspection improves quality.
Chair, I don't know if you are going to have recommendations, but it just seems to me that this committee might want to have a recommendation along those lines about the regular reviewing by the trust themselves of these sorts of issues, if they can, rather than relying on a CQC inspection to come along and pick it up. It's just a thought.
Yeah,
That's
we
all.
will be looking for recommendations.
Yeah, I'm going to say that hopefully I haven't been misinterpreted. But we absolutely have a programme of review and audit of all of our services. I think I was just trying to make the point that I think, that sense of is the CQC valuable? Was it valuable to us as an organisation? My view is that it was, but that was a particular set of circumstances with an almost a rising tide of demand that was overwhelming. But we absolutely do that. But we'd be very happy to share with you how we overview quality. And
But I still think a recommendation would reinforce that message, Chair. But it's up to the committee to decide, of course.
Yeah, thank you. And I think from your comments, both of you, that what we're looking for the people of Herefordshire is reassurance that you all, you accept there are things that you need to do and you are doing those before the CQC came in and did their inspection.
Yes.
Yeah. Next slide, please. Okay, I'll move through these fairly quickly. I'll try and explain what they are and what we're doing differently. So, virtual ward, national initiative a couple of years ago. Bit of central money to design at the time, acute-based hospital, doctor-led service delivered in your own home. That without it, you would require to stay in hospital. So it was hospital-level care in your own home with people going out to your house and digital monitoring. We do have a number of these. We set one up. We've got a frailty one, which is for our geriatric population, and an acute medical one at the moment. There's also something very similar run by respiratory care for about probably 15 to 20 patients at the moment at any one time are being looked after. They could get up to about 30 on that one, I think. But there's some more money this year. Hopefully we've just put a bid in for that from the ICB to extend that to up to 40 beds. So people would definitely be in hospital without it. We've also changed the way it's designed a bit and also opened up the doors to keeping people out of hospital as well as getting people to go home from hospital. So there's a general practice door open now within that virtual ward. So that's something we think we don't want to grow it too quickly. That's a reasonable pace to be growing at it, but it might mean that we might need another 10 or 15 less beds. So eating away at that 35 bed problem. So we should be able to launch that in September should the money be available. And we're just seeing if we can go out to recruitment now. We're just trying to get some assurances from the ICB. Community Integrated Response Hub. This name's changing because nobody ever knows what it stands for when we say CIRA. But it's essentially it's a front door to an integrated sort of set of services. So there's a 2-hour response, where you get a very senior practitioner, often a nurse, supported by colleagues from Herefordshire General Practice via the virtual GP, could go out to somebody's home within 2 hours and deal with what the problem is. Now, that might mean a conveyance to hospital, but more often than not means non-conveyance. It means treated in their own home and then managed like that. They do different levels of response. They do a 4-hour and a next day one as well, but report all that nationally. And it's really about growing that. So we're looking to grow that and change it differently. There's also things like hospital home, which is a much more traditional, more than district nursing, but not as much as a virtual ward type solution. And there's something called OPAT, which is outpatient antibiotic therapy. So you can discharge to home rather than stay in hospital just because you need antibiotics intravenously. So we're growing that as well. Some new devices that allow us to do one dose but split over 4 parts of the day via a machine. So we don't have to send people out 4 times a day to see you. We can just see you once a day in the morning, which is much better for patients, much better for our staff. So that's changing in September. So we'll relaunch that with all those services behind it and that 2-hour response. Improve access to GP out of hours. That's actually access from our ED to general practice's out of hours solution, which is hosted by Herefordshire General Practice. So actually that's outside of contract. That's a very kind offer to try and help us out in ED. And actually, since March, when we re-looked at this, we used to manage a handful of patients at the weekend, 1 or 2 maybe, sometimes none. But I think now we're about 15, 20, I think, at the moment, over the 2 days. So yeah, that really helps. And we've got pre-slotted, got slots already assigned for us, so we can just book the patients into the slots. Some teething problems, but it seems to be getting smoother, and certainly helped after that global crisis of the week with the the IT did help us catch up some work there as well. Diagnostics. What's diagnostics? I didn't write this one.
Is this the really good news?
Diagnostics, and so if we reduce the waiting time for diagnostics.
Oh yeah, yeah.
But yeah, the CDC, which opens next year, will be part of that. Yeah.
Bed capacity and winter planning. Well, that's something that our colleague Andy Parker were putting together. And there's discharge to assess, which is a part of. I'm involved in the first half and definitely that last one. And I work closely with Hilary and her team on trying to design a D2A solution, discharge to assess solution for all pathways, so 0 to 3, to make sure we've got a capability that's timely for our patients. And obviously we get that. Well, today 41, averaging about 35 at the moment, patients in hospital that don't need to be there. If we can get another 10 or 15 of those to be in their own homes, safely in their own homes, at the right time for them with the right support, that's even another 10 or 15 beds away from that 35 bed problem. So the big 2 ticket items are probably virtual ward and discharge to assess. So get people home with the right support, either medical support or care support, and stop some people coming into hospital when they don't need to. It's a particularly interesting initiative we're just about to look at and review this week, which is I'm quite excited by, which is about putting a same-day response team for Pathway 1. So people that need support to go home, but in their own home. So 1 or 2 visits a day just to keep them safe, to do what they need to do. Not medical care, but just care. We're going to trial a service where we can do that for 2 or 3 patients a day. Now, one of our consultants talks about functional decline, that deterioration of a patient just by being in hospital and being isolated from all the things that they normally know. And we think that if we can get them home early, we can stop that decline happening, and we can keep them out of longer term care for longer and keep them in their own home where they want to be. So we'll be able to report on that in about 6-9 months' time. It'll either work or it won't, but it's a reasonably solid investment, I think, in terms of, again, avoiding unnecessary admission to hospital. So again, that's maybe another 3 or 4 off that list, but that'll have a huge human impact as well as hopefully a capacity impact. So I think that summarises the best I can that broader strategy.
Thank you, John. Councillor Andrews, then Councillor Stark, please.
Sorry, could you tell me a bit more about this community integrated response hub? This is people going out into somebody's home, is it?
Yes, I mean.
Who?
Sorry. Yeah, it's actually a team of teams, if you like. So there are a number. The hub is just the place that takes the phone call. There are different capabilities sitting behind that hub, one of which is hospital home, one of which is OPAT. But the 2-hour response is a group of ACPs.
So how do they contact it in the first place?
Oh, that would be professional contacts mostly. There's no patient-led contacts at the moment, so it would be general practice, ambulance service, hospital.
So someone would dial 999 for an ambulance, and then somebody from this team would go.
Two ways actually. I'm trying to keep it. I could spend a day talking about one of these.
No,
things.
just.
There's 2 ways actually we can help the ambulance service out. So we review what's on their waiting list, the ambulance, and we'll sometimes look at those.
Yes.
So we can see what's waiting for an ambulance, and we'll pick some of those off, and we'll go and see them, and avoid the need for an ambulance at all. So we avoid about five ambulance conveyances a day by doing that. So that's some of that pre-COVID, post-COVID I talked about. Is this team working? They go and see patients because they're very experienced staff, very, very talented staff. But then also the ambulance can refer to us if they think the patient needs something, but they can't do, but doesn't need hospital. They can ask us to go and do that, and we'll get to that. That doesn't happen as often as we'd like. We'd like that to be an outcome more often. But
It's just, if I could ask Dr. Hurd there, what's the idea of a GP going out to see a patient then?
I think this will come into the wider picture, which is about how we integrate and work together. There is no kind of one service that should provide this. So I see the community integrated response, general practice, community teams, they're all actually one team ultimately. And I think CIRA is just part of that in terms of making sure that we treat people the right place at the right time, which is what I think a lot of this is about, really.
The CIRA team couldn't work without general practice. They're supported by general practice every day.
Councillor Stark.
Well, I'm going to show my age now and mention district nurses. Now, I don't know where they are and what's happened to them, health visitors maybe, but that seems to be the missing link here. I mean, particularly in a rural county like this one, which I know all too well, come from a big city, exactly what the challenges are when you do represent and you do actually try and help residents who do live away from, as it is, the county town and the county hospital. Is there any role for that type of specialist nurse in this particular wider strategy you're talking about, to provide that link between, as you say, the actual treatment that you provide at the hospital and then the follow-up sort of treatment that can then mean they don't need to be readmitted further down the line? And what are they now? Because I mean, district nurses to me used to be a vital part of the community response in the past.
And they still are, absolutely. And some of us still call them district nurses. They probably, some of them call themselves district nurses, but they also get called community nursing. And they're very much an integral part of the way we deliver care. They're really important. They work alongside general practice. They also do urgent response. They do what I call it, not, I forget what they call them now, urgent calls. So they'll do catheter changes and put implants in for, cannula in for IV drugs and that sort of things for patients that might need them. So, and we're actually looking to change the way that we connect that team I talked about, the CIRA team, and that urgent response part of the community nursing team. We're looking to see if we can reorganise that so we can stabilise the working day of the community nurse, because they often deal with longer term patients in a longer term need, whether that be a wound dressing or sort of managing symptoms. But they're an integral and very important part of the offer.
And do you think you've got the balance right between the resources you employ or centralise at the county hospital and the resources you can perhaps have around the county in terms to help with people being treated at home?
I think Jane's coming in, so.
I mean, there's sort of never enough, is there? But our role, and particularly working in partnership with colleagues in general practice and colleagues in social care, is around trying to make sure that the resources we've got works really well together, so we're getting really good value out of it. So I think we've all seen that there has been a lot of investment in acute care, and arguably, and that's what the new government's view is, and I would agree with, is that we're not doing enough in prevention, we're not doing enough in upstream care, and so we're dealing with too much down the stream when it's an acute an emergency problem. But you have to invest in this bit, because that's the bit where people are unsafe if they're not getting good emergency care. So you have to invest in that. But for me, where the new investment, any new investment, needs to be going into preventative care and into community care, so that over time we can shift that care and shift it all upstream. But those things don't happen overnight. But that would be my view. But yeah, are there currently enough resources to do that? No, but over time, that's where we should be investing, would be my view, and it seems to be what the government's suggesting.
And who has responsibility for overseeing that investment? Is it primary care networks, or is it the Wye Valley Health Trust, or who? I mean, I'm a bit confused here, because we talk about trying to have a holistic approach to the way that you provide health, which is particularly vital in a county without demographics, without rurality. And I would have thought, Chair, that that's one of the main findings from this particular CQC, is how do you stop that flow of demand to the emergency department in the first place, so you don't have that congestion that you were talking about. And I don't know whether we want to think about a recommendation along those lines as well.
I mean, the levels of demand that we're seeing are really high. So yeah, John's talking about a 35 patient problem, because that's 5 extra a day, 7 days a week with a 7-day length of stay leads you to that. But the current problem we have is bigger than that. It's 20 in ED waiting in the morning for a bed, and it's 30 outliers already. So what we do in Herefordshire well is we work well together, and we work well in partnership. And so there are a number of priorities that we've set together to say what are the things that we want to work hard on and want to make a change to. Some of those are through the Health and Wellbeing Board priorities. So how we improve care for children in best start of life, how do we improve mental health. The other part is best value, best place, you know, right time, right place, right care, and that is all about trying to get the care provided in the right place. So we're doing a lot of work, whether that's on elective pathways or in emergency pathways, about how we do it. So I think locally we are focusing and doing as much as we can on trying to deliver that, but there are some national priorities and policies that will always drive us. So, you know, if the policy continues that we are going to drive down elective waiting times from where they are now back to, you know, 95% of people being seen within 18 weeks, that will need a lot of resource and investment in secondary care. So it'll be a combination of both what we can do locally together and how we can prioritise the way we work together, and what the national policies and priorities and funding comes down for. So it will inevitably be a combination of those things.
I mean, you do talk about working well in partnership. We still have that stubborn level of people with minor ailments going to the hospital, which should really not be happening. I do listen to what you said about it doesn't necessarily mean that's the main reason why you have a congested department, but it must affect the performance. So I don't know whether, Chair, we want to say something about encouraging more partnership work and more preventative work in here. I just don't know, because I'm a substitute here and I'm not really sure what else you've discussed in the past about this. That's what I'm saying, Chair.
Thank you. And I think you've already touched on the importance of partnership working, which is what Y Valley are doing with GP services and with local authority services. So I think, you know, that is all going on. Yes, we did touch on the elephant in the room, which is the minor injuries unit debate. I think Councillor Thomas and then Councillor Bartlett wanted to say something.
Thank you. I'm sitting here listening. I've been myself in business all my life, and I'm beginning to think, you know, your well-led requires improvement. I have a feeling if this was my business and I was the managing director, I would be shedding jobs quite quickly, because I think you're overmanaged. Far too overmanaged. I think, you know, we all know that your department is not providing the services it should do, because GPs aren't providing the service they should. Like, I'm old enough to remember going to the GP for all sorts of things that now I would have to go to minor injuries or go into A&E. And when twice have been in A&E in the last, 6 years, and there were many, many people in there that should never be in there, which is thing. But we got to sort of deal with that quickly. And then we can go on to dealing with how you manage your actual hospital. And I'm glad to hear that you're now going to put a lot more doctors on, because that is obviously, when I've been in there, is very, very sadly lacking. You've probably only got one doctor there of any experience, a lot of juniors. So I think I think what's wrong here is the cart is before the horse. I think we need to put the horse back in front and get on with it. And I was going to cover minor injuries, but my colleague here wants to do that, so I'll let her.
I won't rise to the debate in terms of overmanagement and there's too many managers.
No.
But what I would, I'm going to pass over to Mike to talk about general practice. What I would say is that Herefordshire general practice is in the top quartile nationally in terms of patients' experience and access to appointments. So it rates incredibly well. But Mike can talk in more detail about what that means and what general practice is doing.
Just a question, really, thinking about what Councillor Thomas just said. Have you ever thought about reinstating the MIUs in market towns?
There is a review going on across the ICB in terms of the longer term future, but it's not something that we're currently considering.
Yeah, I think if you're looking at one of our neighbours, Worcestershire, they've got minor injury units throughout their county, and they have been working really well. So I think the ICB's input would be really welcome.
Yeah, they're reviewing across, obviously, the whole of the ICB, but I would also refer you back to the data we started with at the beginning. There's been no growth in minor injuries.
Yeah, we noted that. Sorry.
I just
Councillor
say on
Thomas?
that one too, you were talking about this virtual. That would be absolutely ideal because your minor injuries will be in community hospitals, they're called now. Clearing my age. Community hospitals, you have staff there that can treat a great number of things and always did treat a number of things. This ability to be able to to get in and see a consultant, see the problem and advise what's to be done would be absolutely ideal.
Especially now we're getting that new amazing diagnostic service being built in Hereford.
Behind B&Q.
Councillor Bartlett.
Thank you. And following on from this, it's nice to see colleagues have got the same kind of worries that I have. I'm going to go back to a slide, the original Miners by Herefordshire PCN slide that these good people put into the public domain a couple of months ago. But of course, obviously, we had to, for quite proper reasons, hold scrutiny until later than the general election. So the original slide shows Miners by Herefordshire PCN over a much longer time length. So it's showing it from April 2015 through to today. And we're looking at the correlation of the CQC reports that you've had. You'll know back where you were in 2015 on what you're being assessed on. Your assessment band's coming out exactly the same. So when I'm hearing about the amount of work that you need to do because your majors are, they're time consuming, quite rightly, that's where your resources you need to be. But your minors are still really, really high. So when I look at the original slide that we had, bearing in mind that the CQC report that you've got now across those 5 colour bands is exactly the same as it was in 2015. We know one of the major things that we've had as a difference in that timescale is COVID, and there was a dip then. We've had quite a lot of activity between the summer of June 2016 and the summer of August 2019. But overall, your minors are still at the same level as they were in 2015. So saying that having or not having a minor injuries unit makes no difference isn't necessarily true, because you're not having less minors. You're having less minors than you did on the screen on the slideshow where you started from August 2019. You've got less minors than that. But overall, from that CQC timeframe that you're showing us from 2015 to now, your minors are exactly the same as they were then. For some reason, those 2016 to 2019 summer peaks don't seem to be as much of an issue as they used to be. I know from where I am up in Leominster, it is missed. It is sorely missed. I do know that a lot of people are starting to go to Ludlow, and I know from my colleague, Councillor Stark, that he's noticed the same thing in Ross, that people are going to Gloucestershire. I'm very pleased to hear, Jane, and I know we've been arguing this toss for years, I'm very pleased to hear that the ICB are going to do some work on this. But we've got outstanding issues from 2019 health and overview scrutiny, asking for more information to make a good judgment for the people of Herefordshire as to whether removing the minor injuries units was a decision that has no other alternative. And I think, Chair, when we come to start looking at recommendations, not only do we want to hear more about the ICB look at minor injuries units, but I think we need to revisit whether or not we have an appetite through our partnership working to be able to reinstate those minor injury units, because the amount of walk-ins, just personal walk-ins, people going, you know, I've got to see somebody, not navigating the system, do know that it's a little bit more complicated with 111 or 101, one's the police and one's the health. It is a little bit more complicated, and we do know that people just know, they know where the hospital is, so they go to the hospital. And that's, I think, is what's driving an awful lot of the people just coming in at whatever time of day that is. Now, I just think we should be looking again at every way of managing the minors so that it takes the pressure off you guys to get on with the majors. Because looking after a minor injury in a hospital setting is the most expensive way, or a central hospital setting is the most expensive way of doing that. So I personally think, Chair, that we should be looking to use our community little hospitals at Leominster and Ross for what they were doing before. Thank you.
So we'll come to recommendations at the end, if that's okay, if you can concentrate on that one. Councillor Cole, did you want to say something on? No, you didn't indicate. No, sorry.
The community hospital, I mean, should be opened back up. I know you'd say the patients are still the same number, but 90% of all those wouldn't come to Hereford anyway. So you'd have a better, more space to see to the more serious ones. I mean, I'm more concerned when you get them out into the hospital in the beds, because some of that is not a very good experience, I can tell you. You know, when you've increased the people that you employ, but do you actually check whether they're any good at the job before you have them? I mean, I know they may be qualified, but some of them have got a serious bad attitude once they're in the hospital themselves. Really, you know, I mean, some of the nurses are angels and want doubling their money, but some of them should not be there. But it's when but we're only talking about the accident and emergency. It's more worrying to me what goes on up the chain. However,
so this isn't related to the report. No, this is just a ward member concern. Yeah. Okay. Thank you. Councillor Davis, did you want to say anything?
I don't want to jump in on the minor injuries units closure issue and putting all our eggs in one basket in the county, but I did want to ask the question on with the CQC inspection that took place previously in December and the opportunities, as we've heard today, of all the improvements that have taken place. If we had a CQC inspection tomorrow, where would we be?
I think our audits would show that we've significantly improved our management of sepsis audits, our medication audits, provide a level of assurance that says actually we've made the improvements and we've sustained them over the time. It's not perfect, and it's not perfect because we haven't resolved the wider issue of congestion within the emergency department and the wider hospital, but they certainly would see improvement, and that's what they saw on the 20th of December actually, that we'd taken them seriously, we'd made the changes that we needed to change, and on the back of that, that's why we built the audit programme that we've built so that we can demonstrate that our practice has changed and stays changed and embedded. And that's what the next deep dive at Quality Committee in August is about, to look at the outcomes of those audits.
Thank you. So we believe in that SAFE is no longer inadequate and has definitely improved, and we are in a far better place than we were back in December.
Certainly.
Brilliant. Thank you.
Thank you, Councillor Davis. Before we go on to ask whether Hilary wants to expand on that last section regarding the overview of integrating working between adult social care and Moy Valley, I'd just like to remind everybody that generally these are very difficult times, and we all, I think, recognise that recently the government have acted after a report highlighting failures at regulator level. So there is a Dr. Penelope Dash who is dealing with constructing a report in those along those lines, and also Dr. Lord Darcy has done an independent investigation into the state of the NHS. So there's going to be some interesting documents coming out soon. So we better watch this space. So either Hilary or Councillor Gandy, if you'd like to. Oh, Councillor Andrews would just like to say something first.
Just briefly, I would simply like thank you for all this. It's been most interesting. Could I just say that I think our accident and emergency department, unlike Worcester, it's rather like the windmill. In spite of all its difficulties, it's never closed. Okay. They continue to provide, in spite of every problem, continue to provide 24 hours a day, 7-day-a-week service. And I think we should be very grateful for that.
Thank you.
Thank you.
Hilary or Councillor Gandy, did you want to have a minute on the collaboration you're
Yes, so the Appendix 3 that we provided was just to give an overview to the committee of where adult social care, particularly in the area of discharge, which obviously the CQC report was more about accident and emergency, but obviously discharge is an element. And I just wanted to provide some information for the committee around those services that we have in place, and really to underline what John has said about the strength of the partnership working between adult social care and the hospital and general practice, in fact, across the whole system. I think it's, having relatively recently come back to Herefordshire, I think it is one of the strengths of the system in Herefordshire. That's not saying it's perfect, and we know there are areas to improve, but I think it's a really strong foundation to move forward on. Thank you.
Yeah, thank you. And that's been growing steadily since you arrived, I think, Hilary. So thank you for that. Councillor Gandy, did you want to say anything?
Yeah, I was only going to add that although I've only been in post just over a year, I have seen the growth of the joint working partnership between ourselves, the local authority, the acute trust, and the GP services. So I think it is much stronger now than it was, and it's now working really, really hard to make sure that we, it isn't actually to do with A&E, but certainly the discharge to assess situation has greatly improved over the time that I've been involved with this, and in general, I'm very interested in the discussion today. I personally, as I wouldn't say a frequent flyer to your acute hospital, but on a number of occasions, I can't actually fault the quality of treatment I've received, but I do recognise the fact that A&E is very much too small, overstretched, and the waiting times too long. But the actual staff that have treated me have been superb.
Yeah, and I think we just have to wait for these government findings to see where we go from here. Councillor Bartlett, you wanted to say something?
I do, thank you. I've got about 3 questions actually, but I'll start with discharge while we're working on. Obviously, we've just had some briefings around this Emerging Forward Marches partnership with Powys, and we're looking at our statistics here that's telling us that Powys is for the 15% of the work that they bring to us, they are creating 40% of the issues on the blocking of getting people discharged back out to where they need to be. So is this now part of that partnership working as well? Are we actively talking to Powys in terms of the health and well-being strand about how Powys and ourselves work together to manage the resource that both our counties use.
Through you, Chair. We haven't specifically talked about discharge, and I would say that we already work closely with Powys in terms of the discharge work anyway. There's no reason why we couldn't put it more formally into that arena, but just to assure the committee that this council and Powys do work closely with John as well in terms of those discharges, and we will help and intervene where we can.
Thank you, because I mean obviously they're going to, people that live in Powys and want to get home to Powys as quickly as possible as well, aren't they? Bless them. Chair, I do have a couple of other questions about various other bits of the report. Do you want me to carry on, or? Okay, thank you. So two of the things that I'm still unsure about that you guys haven't touched on. Thank you. It was a really comprehensive presentation. So apologies for setting off as a little Jack Terrier there. So one of the things that struck me was the fact that the report had picked up about nurses doing a lot of their training at home, which clearly is not really. They should be having more time to do that. So being nurses and that being supported to keep up to date on the job, so to speak, rather than having to spend time at home. So something about that. One of the other bits that I was looking at was around the cleanliness at night time. So the cleanliness routines, which means that the two people that you've got in the department seem to spend their part of their day when they first start catching up on what hasn't been done, because everybody else has been trying to cover the workload and try and keep the place clean as well. So it's about have you got the right number of cleaners, and have you got them in at the right time? And then I've got one other question after those two, but I'll leave that to be asked first.
It looks like you, Lucy.
So in response to nurses doing what would be their statutory and mandatory training at home, there isn't an expectation for anybody to do that, but there is staff are provided with that opportunity, but there certainly isn't an expectation. So staff should be provided as part of their working hours to be able to conduct their statutory and mandatory training. We do have computers available for staff to leave the department and access the library to do that. And certainly the department are now making sure that staff are offered that, rather than what perhaps individuals felt was an expectation that they had to do it at home because they didn't have time. In terms of cleanliness, so we've introduced a revised way of monitoring the cleanliness within the department, and it's significantly improved since the inspection in December. The difficulty, of course, is accessing the department at a time when patients aren't there. And of course, during the day, the department's heaving and there are lots and lots of patients. And then generally overnight, although the emergency department activity might drop off, we've of course got those patients that are waiting for the bed in the morning. So the 32 patients in the department, which makes it logistically difficult to gain access to an area to clean it. But we have got the right number of cleaners, the right number of cleaning input. It's just an accessibility issue. But as I say, our scores and results since December have significantly improved.
Thank you. Because I say the CQC seemed to, they almost made it sound like you weren't doing any cleaning at night when, and that's good to hear. I just had a couple of other concerns really, or thoughts about the whole of the government system. So there seems to be the CQC were talking about no management sharing of learning from incidents, and certainly we heard from the previous CQC report we looked at that one of the things there was governance around risk registers, who owned the risk, whether the risks were being escalated and being mitigated for and then being reduced back down. So a little bit about the, you know, are managers managing to support staff development better now? Is the learning from incidents and lack of meaningful audits around patient outcomes now being escalated so that everybody knows if there are risks that they are being dealt with, and also within that, if there are risk issues, where does that your governance then sit within the higher governance of the ICB? So.
I'll start. So I'll start with the audit. So I think I alluded to that earlier. We've developed a much more robust audit programme and see periodic reports through to Quality Committee on the outcome of the audits. In relation to learning from incidents, what we identified was actually it was a communication issue. So it wasn't that we weren't learning from them, but individuals were saying, perhaps I'd reported this incident, I didn't hear anything back. And what our Associate Medical Director for the division, Emma Wales, one of our consultant geriatricians, has improved that communication back to it was particularly junior doctors, the junior doctor workforce around incidents that have been reported, lessons learned, and so it was a communication issue rather than us not undertaking the reviews and the associated learning. And then your latter point, I can't remember. ICB. Oh, the ICB. So we have robust internal governance processes in terms of the emergency department reviewing their risks. That then goes through their divisional governance. And then we've got something called Exec Risk Management Committee that Jane chairs that would periodically look at deep dives within the divisions, all of the risks that individual directorates have. And the emergency department sits in a directorate, if you like. So we've got robust arrangements internally, and then I'll let Jane answer how that connects into the wider ICB.
Yeah, so the ICB have a quality committee, and we'll ask for reports, and they have a dashboard of things that they look at. But we wouldn't expect them, and they don't have the sort of level of detail and information and oversight that we would have, because we're accountable for the things that are going on in the organisation. So we do have a link through to them, and obviously anything where there's this sort of report, they would have a role in monitoring to make sure that we were doing all the things that we've said we were doing. But there isn't another separate arm of ICB quality monitoring that comes in on top of what we're already doing and what the CQC do. It would, and that I think is right. It would be too complex and too many fingers in the pie.
Thank you, because I wasn't expecting an additional arm. It's just the fact that it's we have a shared budget now, don't we? So when we have issues, it would be nice to think that the ICP's got our back and we're going to get
and I think
help.
it would be worth saying the ICB sit on our quality committee. Yeah. So we have an ICB representative that sits at all of our quality committees so that they can hear first-hand audit outcomes, deep dives, etc.
Thank you, everyone. Hilary, I don't know whether you want to ask Jo Haycock if she wants to come in. I note she's one of the virtual attendees in the room. She's the head of the adult social care operations. Did she want to say anything regarding the relationship between us and...
I don't think Jo was expecting to speak. It was just if there was any technical questions that
that's
we
fine.
needed answering.
I didn't want to leave her out if she wanted to say something, but thank you very much. Okay, any final comments, questions or concerns from committee members? No. Anything that Carol, Councillor Gandy, you'd like to add? No. Okay, thank you.
There was one other. Sorry, I've just rolled my page there and seen another one to follow you. Yeah, so one of the other things that CQC were looking at was around the being presented with food and drink within the setting, wherever they were in that setting, and that also related to people waiting for discharge as well. So around food and drink, has that improved? Because obviously, if not, somebody's ill and they're not getting a drink, that's not going to make them any better, is it? So around those day-to-day practices, and the other thing as well was about everybody who was there having access to a bell pull if they needed to call for assistance, which apparently hadn't been for every bed or every person had been able to easily call for help.
Yeah, so I'll do the call bell bit first, then I'll move on to food. So for patients who are in fit to sit and for patients who are cared for in our corridors, they won't have access to a call bell, which is why we put in the additional. So we did have healthcare support workers that supported those areas, but that's why we put in additional registered nurses into those areas too, so that they could maintain oversight, because obviously those patients don't have access to a call bell. In relation to food, we review regularly with Sodexo provide our food service to the department. We review that regularly to make sure that there's a hot meal offer, because traditionally emergency departments that aren't congested, that see patients in 4 hours and either move them onto a bed or discharge them, there wouldn't be a requirement to have a hot meal service within an emergency department. So it's normally a sandwich, cheese and biscuit, fruit, yoghurt offer. We have got both, so we've got a hot food service offer, particularly for those patients who've either been there a long time or have been there a long time and waiting for a bed, and then we have a sandwich offer. It's not without challenge and it's not perfect, and I've got a meeting with our colleagues a week on Monday to have yet another discussion about just making sure we've got sufficient of both hot food and so the meeting's more around the strategy to make sure that clearly the nurse in charge of the department has the ability to ask the kitchen at any time for more sandwiches, more soft drinks or whatever's required.
And so in terms of being able to access something to drink like a bottle of water, so for those people that are coming in, quite often they come in with a friend or a family member, and so when they get into the reception area to begin with, are there facilities there where they can actually access a drink or something themselves and take it with them on their journey through A&E?
So,
like vending machines or something like that?
Yeah, so we have vending machines within the department and just outside the department for access to soft drinks and snacks. And then, as I say, bottled water, for example, is available. So if they ask the nursing staff either in the waiting room or anywhere, then bottled water is available for individuals.
Thank you, Lucy. Okay, no other questions, comments or concerns from anyone? So what I'd like to suggest now is that the recommendation for this item is to note the report and the findings, and B, for the committee to make any recommendations to Wye Valley or Herefordshire Council following scrutiny of this report. Could I ask if we've got those recommendations, please?
Sorry. Chair, I've got one recommendation at the moment written down and drafted. I suggest that we take a 5-minute interval just to make sure we haven't got any more recommendations from the committee before we present them.
Okay, so we'll just take an adjournment for 5 minutes. Could I ask that the streaming is I'd like to welcome everyone back to the meeting following that short adjournment. So we are just reviewing the recommendations to this report, and we have three to go through. And would you like to? Yes, please.
Thank you, Chair. The recommendations of the committee are as follows. 1. That the Wye Valley Health Trust report back to the Healthcare and Wellbeing Scrutiny Committee on the outcomes of its work to review service performance to ensure patient safety and outcomes. 2. That the Wye Valley Trust consider the reintroduction of the minor injuries units. I'll repeat that. That the Wye Valley Trust consider the reintroduction of the minor injury units to the Market Town community hospitals to alleviate the workload that is currently being experienced in the only emergency department in Herefordshire. And 3, that the committee receive a briefing on the Integrated Care Board work to review minor injuries units within the board and to report their findings to a future meeting of the Health, Care and Wellbeing Scrutiny Committee. Thank you, Chair.
Okay, so what I need is a proposer and a seconder. Councillor Davis and Councillor Bartlett. So all those in favour? Thank you. That's unanimous. Thank you very much. Just again, like to thank all trust representation, and we look forward to seeing you in the future. Okay, so Jane, I wonder if you would indulge with us, and we'll come back to you on that one once we've had some further discussion. But thank you.
Thank you very much.
Thank you.
Thank you. Thank you.
Okay, so I'd like to move on now to item 8 on the agenda, which is the proposed relocation of the general practice out of our service in Hereford. And the report provides the committee with details of the proposed relocation of this service. Herefordshire and Worcestershire Integrated Care Board have agreed to this relocation, subject to committee discussion and any concerns raised. So today we have Dr. Mike Hearn, he's the Managing Director of Taurus Healthcare, and we have Donna Vickers, who's Director of Planning and Delivery. I welcome you both. And would you like to start, Dr. Hearn?
I should have said this at the outset, I think. I'm sorry. I don't know if I need to discuss it, but I am the ward councillor for this planning application, which I have already agreed to.
That's good.
Yes. It's already been through the system and been agreed.
So, Dr. Hearn, if you'd like to give us a quick run through of what you're proposing. We have had a brief discussion on this in the past, and we haven't brought up any demanding concerns, so thank you.
Thank you. Yes, if you don't mind, Donna has been leading this, so I'll be the support act today.
Thank you, Mike. So just a couple of salient points that that support the report that you'd have had. So yeah, really welcome your feedback on the proposal to move the GP out of hours service from its current location at Station Medical Centre to Nelson House on Whitecross Road. Just a little bit about this service. So it's out of hours urgent care service. So it runs from 6 p.m. in the evening till 8 a.m. in the morning and at weekends. So in effect, when your normal GP surgery is closed. Access is via NHS 111. So that's how you access the service. And the proposal is just for this service moving. It doesn't affect any of what we term the extended access service. So routine appointments, which you can also have at various hubs throughout the county and at Station Medical, they will remain. This is just the out of hours urgent service that's proposed to move. many of you will know Nelson House. It was once in the council's estate. So we believe it's a good central location. There'll be dedicated patient parking, and access to the patient will be at the rear of the building, so off the car park. The main driver really for the proposal is one, financial, around consolidating the estate. So we were operating out of a number of buildings, so there is some financial benefits, but more importantly, there's some real operational benefits, and really connected to what John was saying, because the Community Integrated Response Hub, so CIRA, will also be co-located with us in Nelson House. So that's the proposal, to really integrate the medical support at the weekend and support that urgent care system. So that's really one of the main drivers, is to provide that space for that support. And also during the day, because obviously the out-of-hours service operates out of hours, so during the day it will also offer additional clinical space for wider Herefordshire general practice and indeed other community health teams. So the plan is to create a clinical facility on site at Nelson House, as well as the sort of more corporate back office and operational teams, so that they will all be based there. As part of the process, back in April, Healthwatch did undertake a public consultation where they ran 8 focus groups throughout the county, as well as survey and social media engagement. The majority of the people said it would make little difference, because it's not a reduction in service, it is just a move of service, so same staff, they will just move. It was highlighted around transport, so that does remain an issue. And I think we've touched a bit on it today, when we've got an urgent care system that's quite Hereford-centric. That, so this doesn't necessarily make that any worse or better. That's the reality of it. But the consultation did provide some very helpful recommendations, which will be then incorporated into the design and into the project as we move forward. So, but I think those are the key points from the slides, and then open up for questions.
Thank you, Donna. I think it was a really comprehensive report that Healthwatch concluded with, and a lot of the concerns from residents were easily mitigated. One of them was concerned about car parking, which we all understand there is going to be a dedicated parking area. One was about getting people to and from there, but there's no difference there, because it was at the HMG building, whereas now it's just across the city, the other side. So there's no difference in distance for people. And it's, as Donna has said, it's for the out-of-hours service. It's not going to be stopping anything. It's going to be helping to get enhanced services into that building in the daytime. So, committee members, any questions, comments, or queries? My goodness, no, none of them.
I think it's a very suitable site, Chairman.
Councillor Andrews, do you want to just reiterate what you just said?
I think it's a very central site, and as I understand, I did ask before, I think, Donna, something like you said, 97% of people come with their own transport of one description or another.
Yes, it's mostly car or a lift. Yeah, so very few people would come on public transport to urgent care.
Any comments from? Oh, sorry, Councillor Davis.
Yeah, thank you, Chair. I'd just like to ask one on the clinical facilities you intend to place into Nelson House and the cost of that, because currently at HMG you have access to the facilities that are there and are already instated. So is that going to be an issue?
Yeah, I've actually also been to the HMG patient participation group, and that was one of the questions they were asking around. And currently the setup is effectively HMG will finish at 6:30, and then we kind of set up again. But we can't use all of the same equipment, so because of various things like information governance that gets in the way, unfortunately, and there are also challenges with making sure we get the right stock control. So some of it we have to set up again. And the opportunity of working at Nelson is it gives us a permanent setup. So we don't set up every evening, which is what we do currently. We actually set up so that every evening we can spend maximise time actually delivering patient care. And the other opportunity it also gives us is, at the moment, there is no additional capacity probably in the county actually, certainly for general practice services during the day. And so one of the opportunities we have is to think around actually how can we also use the space during the day. So because HMG, although a big building, is absolutely rammed, so it's really difficult to if we ever, like we've just heard, around pressures around A&E during the day. Well, we're already working with them to support ED at weekends and evenings. Is there an opportunity to think around what we could do during the day? Who knows what we could, in terms of services in the community will need space. So that's one of the opportunities that I think we see exist. But yeah, I completely agree that it's something we have to ensure that the costs are looked at, but actually overall the costs are, this is very much, as Donna highlighted, overall financially, this is actually the cheaper option as well for us to consolidate services together.
I think it's really important that they have a permanent base so that they don't have to keep moving out of. Councillor Gandy or Hilary, any comments at all or not?
I'm quite happy.
Okay, thank you. So the recommendation to us, the committee, is that the covering report, that the committee note the presentation and that the committee endorse a proposal or provide Taurus with recommendation action to enable the committee to endorse that proposal. And I think we're all clear with that. And we fully support it. So can I have a proposer and a seconder, please? Councillor Andrews, proposer, and Councillor Davis, second. All those in favour? Unanimous. Thank you very much.
Thank you.
And thank you for being so tolerant with the time this afternoon. It's appreciated. Thank you.
Thank you.
Thank you.
Okay, so we move on to the final agenda item, which is number 9, the work programme. If you don't want to stay, that's fine. That's absolutely fine. Just wondering whether Daniel was going to be able to
leave on that item. So should we just have a 5-minute adjournment again, just to let people leave.
Okay, so I'm sorry, we need I'd like to welcome everyone back to the meeting following that short adjournment. So we're just going to review item 9, which is our work programme. It's all in the paperwork, and Daniel's going to lead us on this.
Thank you very much, Chair. The committee met recently to talk about its work programme and to plan its work programme for the year ahead. And the work programme that is presented to this committee is appended to the papers in this report. Since that meeting, the committee has carried out some additional work that it would like to bring to the committee to agree to carry out in September and October. This follows cabinet meeting a couple of weeks ago where the all-age carers strategy was presented and agreed by cabinet. At that meeting, it was suggested and agreed informally, of course, that scrutiny would look at the action plan resulting from that all-age carers strategy. So what we propose to do is to bring a terms of reference for a working group to look at the action plan and to report back to this committee in due course later on. We'll share this suggestion with the Scrutiny Management Board and with the Children and Young People Scrutiny Committee for their agreement for us to lead on this piece of work going forward. It was felt from conversations with officers that a working group would be more useful for this particular piece of work. It would allow more immediate feedback, more rapid feedback to people who are drafting the report, and it would also provide a better environment for us to make suggestions and work to deliver some of the detail in that report. So with the committee's agreement, I will bring the terms of reference to the September meeting, which is in addition to the work programme that's in front of you at the moment. I'd just like as well to share some of the work that we've been doing around this work programme as well. And again, this will be presented into the September copy of your draft work programme.
It's October. Yeah.
Sorry, my apologies. September, it's always in my head. It's actually the 3rd of October, that committee. Apologies to those of you who are listening in. We've at our planning meeting, the committee agreed that it would like to do a lot more work around its formal committee meetings to improve, increase, develop its understanding of its remit. So as such, we have put into place a couple of briefing sessions already, one around the Joint Strategic Needs Assessment and one around community transport. We're continuing to work as well with officers to deliver the forum/briefing sessions that the committee have previously agreed around home care providers and care home providers, residential care. We've not been able to agree dates with officers on that. That's quite a complex piece of work, and there are some commissioning complications that we need to bear in mind before that work comes to fruition. But I just want to assure the committee that we're continuing to work to that, and hopefully I'll have some news to present to this committee on the 3rd of October, which I believe is when the next meeting is. I do believe as well that there have been a couple of other topics that have been raised during this meeting and in early meetings around further briefings that you would like. So what I will do is to make sure that when you next receive a draft work programme, that all of these training, development and briefing sessions are included in there, so the public and others can understand all the work that you're doing in preparation of these meetings, so they don't appreciate these just happening in a vacuum. So the work programme as it stands at the moment, with the addition that in your September meeting that you would agree to receive a terms of reference for a working group around the all-age carers strategy. Thank you very much, Chair.
Thank you, Daniel. The other thing I wanted to ask committee members if they've got anything that they think we need to add to this programme. Anything, Councillor Stark?
We had a debate at SMB informal about where the examination of the budget should lie, and there's some discussion around some of that work actually coming back to the 4 thematic committees like yourself. I would have thought you would have an interest in looking at savings in this area and making sure that the savings are pinned down and achieved. That's one thought. Second thought is, when was the last time we reviewed ambulance services?
About 8 years ago.
I don't want to crowd out your work programme.
No,
'cause
no, that's
it may
fine.
or may not be a priority for the committee, I don't know. But I would have thought ambulance services would be one of these areas. But certainly the savings that have been, shall we say, proposed for Hillary's directorate, that should be, I think, looked at by this committee. Thank you, Chair.
Thank you. Yes, definitely. The Scrutiny Management Board did discuss that, and I think we do need to put that on our agenda for the future, that we look at budget savings.
Which I totally agree that we should, and thanks, Louis, for bringing the SMB discussion back to the committee. Would we then do that as a committee agenda item here, or would that then be done as a briefing to feed into Scrutiny Management Board budget setting process?
I think that's something we have to discuss in the future, which is the best place for it. So, yeah, we will.
Which is the best format for it, rather than,
I think with both of these ideas around the West Midlands Ambulance Service and with budgets, I think it would be wise for the committee. I think you can agree that this is something that you need to look at in detail. It needs more work to shape it. Do you integrate it into some of these topics that are in your work programme already, or do you do a separate, let's look at the budget within the remit of the service areas that we cover? There's different ways that you can do it, and I think it just needs some more thought. So I'd suggest that you agree to have another planning meeting and develop your work programme further around this.
Thank you, Daniel. I think that's good advice, and especially in context with today's meeting when they talk so much about conveyancing. So I think the ambulance service should come and talk to us.
I just remember the other topic as well that has been suggested as a briefing for you, and this came from an all-member briefing this morning around an expected, anticipated CQC inspection, and there was a suggestion that perhaps the committee receive a briefing on technology-enabled living as well. So if the committee are happy with that, we'll pursue that for you.
Chair, just to point out that that has been on the long list for quite a while, so I do welcome the fact that it's now become a live topic.
Yep. Councillor Thomas?
Well, following on from today, when are we going to look at the Wye Valley Trust emergency care again, emergency treatment again? Because we ought to really have a date in it rather than letting it slip.
We will get a date.
I think what I would advise against this committee doing is to say, oh, let's look at this at 6 months, let's look in 12 months, because sooner or later you end up just accruing regular items on your agenda. I would suggest a conversation again when you have your planning meeting is to start liaising with the Wye Valley Trust and work with them to find an opportune time for them to bring this work back to you. Obviously, you've made a recommendation around this, and although obviously the Wye Valley Trust have yet to agree that recommendation, I think they seem to sort of indicate informally that they would be happy to do so at some point. So rather than say now 6 months, 12 months, let's have that conversation with them and bring it back at the right time.
Okay. The other item, I wondered whether we could look at when we get Talk Community back, because they've done their review now. So I think we need to contact that department to add it. And if they are able to do it on the October the 3rd meeting, so be it. I think that would be a really good move. Okay, so this is the last item. So the cover. Yeah, so the covering report recommends that the committee agree to the draft work programme, which will be subject to periodical reviews as the basis for the primary focus for the remainder of the municipal year. Proposer and seconder? Who are? We've got Councillor Davis, Councillor Thomas. All those in favour? Louis? Okay. All right, everybody.
Well, it's just, well, I don't know what the position is when you're a substitute.
Okay. Anyway, we acknowledge your comments. Thank you. Okay. So therefore, item number 10 is the date of the next meeting, and as we've already said, I don't know how many times, it is for Thursday, the 3rd of October, going back to a Thursday, not a Monday, that one, so that's at 2 o'clock. And
I will give my apologies now, Chair. I shall be away on holiday, and I've asked Councillor Tillett if you make sure he's free of mayoral duties to attend.
okay, thank you. We'll accept that apologies at this point. I'd just like to thank everybody again for their attendance. Thank you, Daniel. Okay, could I ask that the live stream has